And our second speaker in this session will be Daniel Roche. He's Director of Evaluation, Quality and Strategic Planning at the University Hospital in Quebec, the CHUQ. He's going to talk about their strategic and evidence-based approach to resource reallocation. Dr. Laroche. Mr. Laroche. Well, it would seem that in order to avoid people from falling asleep here, we have to add extra elements. So I'm going to take a couple of minutes myself, just a few seconds. Danielle had asked me to be present, and unfortunately I have an appointment coming up. But so very briefly, the idea that Danielle is going to present to you is really an outstanding one. It comes from the team that is responsible for the evaluation, the quality, and the strategic planning at the CHUQ, the Quebec University Hospital. This kind of hospital comes out when you're in this large-scale hospital center, one that has a critical mass. Well, since July of 2012, the CHUQ is the largest hospital in Quebec. There's 14,000 employees, 1,700 physicians, 1,800 beds. So it has the critical mass, 550 researchers. All that to say that the project that Danielle is going to present to you is possible because we have the avenues to explore this whole issue further. So I'm not going to take any of your time. You can read the figures here, and I'll just give the floor to Danielle very quickly. And I would also invite you to contact us. We love to get to visitors at our hospital to see how the project is moving ahead. Danielle. Thank you, Gertrude, and thank you to all of you. Thank you for allowing me to speak to such a prestigious group of people. A little story to begin. A few years ago, I worked at the Health and Social Services Agency in the national capital, and one day a physician, a neurosurgeon, a highly reputable neurosurgeon who works with me today in my office, he came to tell me in a not very pleasant tone, well, that we don't know how to work, we don't know how to take patients' considerations into account, we don't know how to organize services in the Quebec area. And I was listening to him as he talked on, and I was thinking of my son when he'd come into the living room angry because I was a bad dad, because I didn't give him the Wi-Fi device that he wanted, or the proper level of megabyte bandwidth that he needed for his video games. And at the time I had told my son, well, listen, if you can find something in the house, in the family budget, that we could visit, that we could review, well, then I'm ready to look at our plan, the internet service that we have at home. So he kind of wasn't as angry. And 2 days later, he said, well, you know, Dad, we don't really listen to pay TV, to these, the pay movies on Super Channel. Perhaps we could eliminate Super Channel and put that extra money onto the internet. And I said, okay, even if it was going to cost me $2 more a month. And that's the idea behind the project that I'm going to present you today. I worked along with Dr. McLean and Mark Rains and Dr. Martin Coulombe. We are in the extra program here as well. But first of all, to explain the context, there were 3 studies that have estimated that up a third of healthcare expenditures in the USA could be avoided out of $700 to $910 billion spent every year. Maybe 45% is used suboptimally, perhaps an overtreatment, a use that's not justified by the evidence, an inefficient use of resources, and 55% go to fraud, abuse, bureaucracy, price fixing, and so on. But in the Canadian context, we only found one study from the Canadian Association of Radiologists, study done in 2010, and it showed that 30% of diagnostic imaging procedures in Canada might be unnecessary. Now, when you think that the total expenses for DI in Canada are $2.2 billion per year, well, you might see the potential savings that exist there. And when everybody says, oh, we're overspending, we have no money left, well, perhaps we could look a little further. At the Quebec Hospital Centre, we set up this committee of major cost generators. It's a subcommittee of the management committee and it is composed of assistant directors and different service heads, and it exists in order to identify the different levels of expenditures within the organization, to identify the major cost generators, and to identify strategies to save money. We looked at medical and office supplies, human resources, specific professional practices, and the main strategies were to focus on reducing inventories, to reduce the diversity of inventories, or to act with suppliers as necessary. One of the projects that we undertook that really followed our vision here was to work with the anesthetists in the hospital to look at all of the different types of tubing used in the operating rooms, to see if we could not streamline, if we could not reduce the great variety of tubes used in order to have an RFP for a smaller number and have savings. And they agreed. And as they agreed, as long as the savings were reinvested in their own field, and since they were just setting up a chronic pain clinic, they agreed, and the savings of $300,000 were reinvested in this chronic pain clinic. Our project then was to include the consideration of evidence in the major cost generator process. Now, the process already existed, but we want to include more evidence. We want to make sure that we have a medical leader on this committee, this medical leader that would help us to influence the rest of the physicians. We want to develop a disinvestment process based on the literature. We know, for example, that in the U.S., there's a campaign that's called Choosing Wisely. It's really interesting, and it's going to help us to reconsider different options as well. Now, we do have data, but it's a wall, and it doesn't always allow us to go as far as we want to. But with time, we will be able to go further. But first of all, we have to develop the process for this disinvestment and to identify reallocation possibilities to make sure that it's a win-win situation. Now, the relevant factors, well, of course, an easier access to resources might lead to overuse, and the process within the walls of the institution cannot reach the same level of savings that we would in a whole provincial or national program, for example, physician compensation, medication, and so on. But there's still a major potential there. If you look at a facility like ours, just for medication and supplies, we spend $155 million per year. And if we were to save 5%, that would be $7.75 million a year. The basic principles, very quickly, once again, this voluntary disinvestment and reallocation based on evidence, based on our own situation at our hospital in Quebec, and based on the participation of the clinicians who are really at the center of the whole project. And the reallocation is made within the same department and the units that generated the savings to the tune of 95%. And within our health technology assessment, then we retain a meager 5% to allow us to go a little further on this idea. Initially, the focus should be on the overuse of medical resources. Our first target should be this overuse because it is a major factor that does explain the high level of healthcare expenditures. And we were talking about patients earlier, and we will do so again at the end of this panel. This often exposes patients to unjustified risks. Now, this is the cycle that we used that you can read on the slide. The benefits for patients, well, that's the theme here today. We want to improve the quality and safety of care. We want to increase access to care if we can do more with what we have, and to avoid interventions that have no added value, that are avoidable. The major issues are the resources dedicated to the definition and support of disinvestment mechanisms. As our friends to the south say, we have to find something to prime the pump. We have to put some money into the machinery to do the studies, to make sure that we support the disinvestment movement. And we've already said so, but there are limits to of the information systems. We have to look at those systems and improve them. We have political challenges as well as clinical and social challenges that are related to the withdrawal of any established technology. Of course, there's always resistance to change. There's the availability of evidence, of course, and the compensation system, which in Quebec is a fee-for-service.